Thank you very much. Thank you for inviting me. And thank you for the introduction, John. And thank you for the focus of tonight's session. Just make sure I have everything that works in the right order. I should have done, yeah, that's okay. So, my name's Rob Simister, as John has mentioned. I'm a consultant neurologist and a stroke physician. I have been lead of the comprehensive stroke service since 2012, out of the HASU since 2010. I came first to Queen Square around 1999, and my research then was under the excellent supervision of John, and it was in epilepsy. And it was looking at the application of imaging of brain and brain metabolics to the study of seizures. And at that stage, I was interested in seizures, this strange experience that sufferers must have, where all of a sudden, on a normal day, they could find themselves on the floor. There would be a passage of time, and they might have injured themselves. And this felt such a strange experience that it was very worthy of further research. And I finished my research and realized that I'm really a clinician and have returned to clinical practice. And my main drive, I think, on reflection is being part of the stories, in touch with the stories of the patients that I treat. And after the strangeness of epileptic seizures, something even more profound is what I'm involved with in a day-to-day basis. Imagine you're in the street. It's a normal day. You have your plans for the afternoon, you have your plans for tomorrow, you have your hopes for your career and your family, and then something happens in an instant that takes all of that away. Immediately afterwards, you fear for your life for some days, and afterwards you're faced with this opportunity of maybe living now with a body that is paralyzed down one side, or maybe a complete loss of language, or maybe loss of memory or concentration. And all those hopes you had that day in the street completely evaporated. And that's the reality of stroke. And confronted with that reality, 150,000 patients a year ask three questions commonly. Why did this happen? What can you do now to reverse it? And if it isn't reversible, what will I be like in 1 month? Or 3 months, or a year? Will I get my life back? And I'm thrilled that we're here today to talk about stroke, and I'm thrilled that I have a chance to tell you what our service is doing to try and answer those 3 questions. And my instinct about all this, having worked in the NHS for a while now, is to make real change, real lasting change. It's not about what one individual does, it's what a team of people do, a collaboration across services. Just as the brain is a network of interlinking circuits, we need to work as a group of clinical teams, research teams, linked hospitals, linked commissioners to try and provide a coherent solution to the big problems, and stroke is a big problem. When I came in 2008, stroke was already being done well, and that's thanks to the vision of Martin Brown, who set up the stroke service here, and to the leadership after him of Nick Lossif. And since 2008, we have done things better, I think. And I'm going to talk about some of those areas. And now we're starting to do better things. We opened the HASU in 2010, and that stands for Hyperacute Stroke Unit. And that is the front door for North Central London and sees about 1,200 patients per year. And in the last annual mortality data report, as John says, our mortality rates were excellent. In 2011, we were designated as only one of 8 NIHR-funded hyperacute research centres. And more recently, with the help of the Biomedical Research Centre, we've set up a model of care on the HASU, which provides excellent state-of-the-art medical care and assessment, but also a platform for homegrown and international research that looks into the cause and consequences of stroke at the front door of a cohort of patients that are managed through North Central London. And big research agencies are coming to do their work here. I don't know if you saw details recently of this patient who had had stem cell research stem cell in transplantation post-stroke and had gained some recovery and function in his arm. Well, we are one of a very small number of sites in the UK who are involved in that study and have our first of our own treated patients in that study later this month. We're involved in a study called EuroHype, which is trying to look to see about whether you can reduce inflammation after stroke by cooling patients. And we're also involved in a study that is of particular importance to today's talk. I'm going to spend a moment or two talking about it. And it's called Medus. And the principle of that is, if you have a blocked vessel, and the top slide is a blocked vessel, it doesn't matter, and the vertical line is what you could imagine is a flowing channel of all that you could wish for in terms of clot-busting agents. If you have a blocked vessel going out to the side and there is no flow in that blocked vessel, the clot-busting agents don't get into the core of the occlusion, and you get a stagnant column of blood, and it doesn't matter what you give into the vein or into the artery, the agents will not get at the occlusion. And this is the clip of the pilot study done by the company. And this is a time-lapsed cine film, and you can see almost nothing is happening. And that's a clip of how quickly, or not, the agent is eating through the stagnant column of blood. And this is what their trial agent did. And their trial agent is very interesting. These are nanoparticles. They have an iron core, and a magnetic field whips them up into a vortex, which drills a hole through the center of this stagnant column, allowing the clot-busting agents to get at the site of the occlusion. Now, if this works out, this might change everything in another way in terms of how you can quickly get vessels open. But you can see what's happening. You saw nothing on the top one, but what you're seeing is a channel being opened in the vortex provided by these nanoparticles. But mainly what I want you to know is, at the moment, the situation we have is what we have at the top. A blocked vessel, a stagnant column, no way of getting your agent to unblock the vessel. We also have a study that I should just point out, because it's incredibly topical at the moment. It's Metro 24/7, and that is speaking exactly to the problem of 24/7 working and weekend effect. It turns out that the idea of a weekend effect is incredibly simplistic. There are many things happening in hospitals in the day, at night, at weekends, and the only way you can really study that is by having people on the ground asking questions about what's going on. And Metro 24/7 is designed to do that in the London HASU model, where all these units are set up to be exactly the same and collect excellent data. Right. That's a bad stuff. Sorry about this. Shouldn't be happening. I'm going to talk about some of the other things that we have done since 2010. Large strokes do badly. Large strokes because of a blocked vessel, or large strokes because of hemorrhage. And we realised this very early on the HASU at UCLH. And with the benefit of the support from John at the Queen Square, we set up a system to take the sickest of the sick stroke patients and put them on our critical dependency units here at Queen Square. And we've audited this carefully, and it looks like our practice was the right way. And this is data that was presented in Barcelona at the European Stroke Organisation last month. The blue line is the blue line drops off quickly, which is survival, so more deaths by 90 days in the group that stayed on HASU. The red line is the group that came across to Queen Square, showing that we have developed a model. We are proposing a model whereby if you can get people through the very early phases of very large strokes with best care, then perhaps their mortality isn't as bad as we thought it was. We also realised that stroke is an umbrella. There are many specialist causes for stroke, which have their own channels of investigation and treatment and prognosis and follow-up. And what a very complex service like ours needs is very complex clinics. And we have a series. We have 2 specialist hemorrhage clinics, one for spontaneous hemorrhage, one for hemorrhage due to an underlying vessel rupture. We have a clinic for large vessel wall disease. This is a Moya patient, and we have the only Moya clinic in the country. We have a clinic for these black dots, which are called microhemorrhages, and they seem to be related to an underlying pathology called amyloid, which is a cousin of Alzheimer's disease, and is increasingly commonly recognized as a cause of hemorrhage in the elderly. And we've developed a menu of incredibly specialist brain function recovery clinics, of which one of the absolute successes is Nick's clinic, which he's going to tell us about, and another one perhaps is Alex Leff's clinic, which helps patients who've lost the ability to read after stroke to recover that with use of innovative web-based technology. We've done a whole series of other things. We've set up a screening system so that all patients who come into the HASU will be screened for common infections, which are a missed cause of stroke in many cases, particularly HIV, which is common in London. And as a consequence of that work, we've forged links with Malawi, where stroke survival is in the order of days or months, in order to create a setup where we can impart our experience of service setup to try and help them make some basic gains. We've created a model for recruiting patients to be screened for a battery of possible metabolic triggers for stroke at the front door, currently all unidentified, in a study called Signum. And we've had another study also funded by the Biomedical Research Centre, which tries to look at why some people recover after stroke and others do not, by looking at the start condition on the HASU and detailed cognitive and physical functional assessment at the time of follow-up. We've developed our own paperless system. This is a digital technology. You see our nurse, Selina, and I think a photo brushed Richard Perry, our doctor, showing that you can enter on the go, pen and paper functionality, one entry, off to audit, off to performance metrics, off to GPs, off to discharge summaries, same data, one entry. Our team freed up to be involved in clinical care. Once you have that, you can then attach it to a whole series of other technologies. Connect is something you might have in your lounge as a movement sense of a game player. But we're going to use that, we're about to use it, as a way of creating body maps on the HASU that might, if everything comes out as we hope, be an early predictor of what early movement after stroke looks like. But it might even just do something as mundane as predicting fall 10 seconds before the patient actually gets out of bed. We've also used this mobile technology to create a mobile telemedicine system. The problem with telemedicine systems, if you're familiar with them, is mostly what you do is you park your patient in front of the camera whilst the consultant somewhere else asks you to move here and move there, and it wastes time when your time from door to needle is meant to be less than 30 minutes. Far better, in fact, to move the telemedicine with the doctors. And that's what we do. So here's our simulation. We do simulations all the time. And this is the doctor wearing camera glasses linked to our digital tool, seeing the patient. This is before he learned how to keep his head still. And what you'll see in a minute is that when he keeps his head still, you can see what he's seeing. Far better for me, as the opinion giver, unable to see the patient, to see exactly what the team are seeing. And there's so much that is lost when there is phone conversation that is gained when you can see it in real time. But that's one thing. What about watching what the patient sees? And the problem with stroke is often patients come in and they have lost language. Imagine you come in and we have a way of visualizing what we are looking like to you as a patient in an extremely scary environment, unable to understand what's going on. And we are grateful for the National Brain Appeal for a seed funding to allow us to study that with an anthropologist from Queen Mary's in Roehampton, to try and improve our non-verbal communication, to try and improve the experience of being in hospital in this profoundly scary environment and unable to understand what on earth people are saying to you. In 2015, we could not repatriate our patients to the sector. And we went to the urgent and emergency care network and said, this is a problem. And they said, the problem is the whole pathway. It's not just you to your hospital. It's we can't move them from that hospital to the next, and that hospital can't move them to community. So we set up a collaboration with all the collaborators, all the stakeholders in the system. This is hospitals, this is commissioners, this is community therapists, and this is our model, and it will create a unique map of what's happening in the entire pathway in stroke in North Central. And this is the rough data set so far. You can play with the parameters, you can make length of stay at North Middlesex go up by 2 days and see how that cascades across the network. And that's good enough in us understanding what's going wrong and where it's going wrong in the whole pathway. But we can work really smartly. We can use this model in due course to say, if on Tuesday 3 extra patients come in to our HASU, all with language problems, all due to go to Barnet, we can now notify the Barnet therapist that in 3 weeks there will be a spike of referrals for language community-based therapy. We can work smartly, and in the NHS at this time, the optimal, flexible use of resources with prediction of what need there will be a real asset. So that's a lot of what we're doing at the moment. We're really keen for you to hear about Nick's clinic and the model for how we can improve recovery after stroke. But I'm now going to spend the last part of my talk introducing the work that Pete does. We are profoundly grateful for the incredible asset that the neuroradiology service has for us as stroke doctors and for the rest of the hospital. And I'm going to describe a story of a case that Pete's treated for us that is incredibly relevant to where we think stroke care needs to go in the next 2 years. And I'm going to call her Sally, but that's not her name. Sally had a stroke. She is young, and she had it in the morning. Dense right-sided weakness, and she lost ability to speak. Her daughter phoned her and knew immediately there was a problem with her speech, and did what daughters do, and sons and fathers, and came round to see for herself, and rather than calling the ambulance, but still got there quickly and found that her mother was not right. Her mother had been up and washed and dressed, and clearly this had happened since then. So the ambulance came and took her straight to our hospital. This is a person presenting with what we think is a clinical stroke within 3 hours, within 4.5 hours really if we want, and we know we're going to give clot-busting medicines if the scan looks okay. No contraindication. But we're also thinking, can we ask Pete whether he can be of service if the conditions are right for a clot retrieval technique? So, she had a scan whilst we're thinking about this, and the scan shows a white line on the image on my right. That white line is blood clotted sitting in a vessel. Exactly what I showed you on that slide earlier on. There is a blocked vessel, and there will now be a stagnant column of blood in front of it. We will give clot-busting medicines through the vein, but we know it will not, in most cases, work through that stagnant column of blood. Despite that terrible appearance and her weakness down the right side and her language loss, her brain scan at this time looks pretty good. She had what's called a CT arteriogram, which is where we inject contrast to show up the flow in the arteries. And that showed, on the scan nearest me, a gap, which is the occlusion. That's blood not going through that vessel. And the image, the other side, is really, really relevant because it shows, despite this main vessel being blocked, the vessels behind it, distally, in the surface of the left side of the brain, still are showing as a pacifying. She has collateral flow. She has flow that is analogous to the way we get to where we want to go when the motorway is blocked. They've found a way round. And between us all, we have no way at the moment of predicting who of us will have good collaterals. And we have no way of knowing how to improve our collaterals, but they clearly are extremely relevant for what we're talking about here. We did refer to Pete because it was a working day within working hours, and Pete's able to do something in that time window. He was able to take her to his cath lab, and he was able to remove the clot immediately. This lady, if you remember, came to our hospital paralysed down the right side, unable to speak, with visual loss on the right side of her field. This is her scan after we'd treated her. She has a tiny area of damage in the deep part of the left side of the brain, and she walked home at 3 days with mild hesitancy of her speech and a mild hand weakness. She would not have done that, statistically, if she had just had the clot-busting medicines, because of this stagnant column of blood in front of the occluded vessel. And this was in early 2015. We didn't know why she had done so well. And then all of a sudden come 5 studies with names like Mr. Clean and Escape and Extend IA, and 2 other studies that have been presented at conference but not reported in journals, all saying exactly the same thing. All studies tried to select people, firstly, as a mandatory requirement when they had this occluded vessel, and also in general to try to look at what was relevant to the ones who did well. They tried to look at this idea of collateral flow, and they tried to look at another thing, which is brain perfusion. And they all said the same thing, and they were all strongly positive. And in April 2016, all that work was put into one meta-analysis called the Hermes collaboration. And this is one of the primary slides from that work. And this is called a forest plot, and the vertical line is the midline. Anything this side is a good effect from clot retrieval. Anything to the other side is a bad effect from clot retrieval. The further away from midline, the better it is. And this plot, the meta-analysis, no heterogeneity in the studies, they all showed the same thing when you analyze it, showed whichever way you cut the cake, big strokes, small strokes, older patients, younger patients, they all did extraordinarily well with clot retrieval. The average is they did at least twice as well as they would have without clot retrieval, sometimes 3 times as well. You only need to treat 2.6 patients for an additional patient to move from the dependent group to the walking with a stick group. You only need to treat 3 patients in this group for 1 additional patient to return to an independent lifestyle. This isn't just with an average stroke, this is with the type of stroke that Sally had. They've also done further sub-analyses. The biggest of all the studies was called Mr. Clean. Mr. Clean has looked at whether these collaterals were important, and it turns out they seem to be very important. They can grade the collaterals. It's a simple score. You can't see any 0. They look normal 3. And this is a plot of modified ranking scale. This end is severe, and the score of 6 is death. At the other end is complete recovery, and everything in between is increasing severity towards mean. And you can see when you have no collaterals, the mortality was high, and the good outcomes were limited, irrespective of whether you did clot retrieval or not. And down here, with good collaterals, mortality is low. Recovery is good, and even better if you can do clot retrieval. So in 2015, when we treated Sally, we did not know this, but it turns out she had great collaterals. She had an occluded vessel. She had a small area of damage on her baseline scan. And this leads the Canadian group, who were one of the massive champions for this being rolled out everywhere, to say, is there a clot? Is there evidence that there is a reasonably preserved brain? Are there good collaterals? Should you go and find yourself rapidly a service that can do clot retrieval? And the important thing about this is that the clot retrieval service at the moment in London is really only available across a small number of centres through working hours and not at weekends. It's also clear that what the trials were showing were just people who had very good outcomes. If you look at everybody seems to shift forwards. So everyone does a bit better, the group does a bit better with clot retrieval, even though some do very well. So what we need to do somehow is to create a map of London whereby wherever you live, you can have access to a clot retrieval service 24/7, just as we have come used to in London a clot busting intravenous service 24/7 in the HASU model. So in 2010 we organised ourselves, slightly painfully, into a hub and spoke model, And in 2016, we need to organise ourselves through collaboration into a super hub and spoke model, where the super hub treats a small number of patients with the largest type of strokes, knowing that if they can treat them quickly, they can affect a really rather amazing recovery. So with that in mind, I'll finish my talk. Happy to take questions, and I'm looking forward to hearing Nick and Pete tell you more about what they do.